morning. I had a case study presented to me yesterday from a young doctor, new in practice, and I thought it warranted a good, quick review on a pediatric exam of someone with a torticollis. And so, baby had a torticollis. I would consider it a severe torticollis. The chin was rotated far past 45 degrees. There was the lateral flexion, and but in addition to that, the skull measured 1.5 centimeters larger on the right side than the left. That would be considered statistically significant for sure. For me personally, anything less than 0.5 centimeter, I'm not that concerned about. In fact, I think that I'm within 0.5 centimeter in terms of my measurement from time to time, and so I question sometimes the specificity of those measurements. So 0.5 centimeter or more I consider significant. Had slight closure of the right eye, and on observation, all the reflexes seemed relatively normal to her, she said, and baby wasn't really fussing that much, but this was their natural posture. The history was a forceps delivery with a slight scar on above the right eye to baby. So if the scar is here, then the forceps must have been kind of the anterior corner here and the posterior corner on the opposite side, as sort of the main areas. The forceps are about 2 inches wide, maybe 1 3/4 inches, depending on the ones that they're using. So either way, the pressure was all at the front there on the right side. I know in the camera it's the opposite, but it's on the right side. And she didn't know where to start. And it's not uncommon to get a case where you don't know where to start. But and I want to teach you how to think through any tough case. Remember, your job is not to have all of the answers. That's why there are specialists of everything, because nobody has all the answers. So that's the first thing. Give yourself some grace. You have to realize that many of these doctors who are so-called specialists are also not fully aware of all factors, and they understand that, but they are certain about what they do know. And so in your case as a chiropractor, go into it being certain about what you do know. So you do know that the head should be straight. So posture, you're able to evaluate posture. So you have automatically a means of remeasurement. Number 2, you know that the body's supposed to have a particular range of motion. They don't have it. Again, that's what you're documenting. Number 3, you know that when you measure the 2 sides of the skull, they should be relatively even. They're not. You have another measurement to go by. And so part of your care then is implementing care to provide answers to the things that you're qualified to measure. So let's go to the skull circumference. If the skull circumference is different from side to side, and it depends on who you read, but for me, the first thing I'm looking at is the temporal and parietal suture. Now you remember that there are the 2 occipital bones, the 2 parietal bones, the 2 frontal bones, and the 2 temporal bones, along with the sphenoid, which has a prominence that comes out the right side and out the left side. So they're not separate bones on the sphenoid. That's actually one bone that goes through the skull. And the idea there is that as soon as you know that the temporal bone, the suture line, is like this. So if the suture line is like that, then the temporal can only subluxate on top of the posterior, or superior, on top of the parietal. So temporal over parietal is the only subluxation that can happen there. You can't have parietal over temporal. And so if that's the case, then you want to push inferiorly on the temporal bone and pull superiorly on the parietal bone. That's it. It's not really rocket science, and it's just enough tension to cause your fingers to blanch at the end of them. And I've seen some people use a little bit more force than that, but most times in somebody 5 months or younger, I find that's more than enough force. So that's the skull part. So now, what about rotation? So we know that the SCM is intimately involved in cases of torticollis, and we know that neural innervation to the SCM comes from the top part of the cervical spine. you know how to assess that. So if range of motion is restricted, first thing I want to look at is remembering that I think it's 55% of all rotation in the cervical spine happens at the level of the at the level of C1, C2. And so that rotation happens in the upper cervical spine. So if that's the case, that's the first area that I'm going to go. And I'm going to assess for subluxation, however I do that, whether it be like a thermal, whether it be palpation, whether it be whatever the case is. And then I'm going to go and do my correction there. So now you have correction for the rotation, you have correction for the skull, and then the last thing you're looking for is correction for the lateral flexion. And for the lateral flexion portion, it's oftentimes a dural release, either in and around the skull. It could be a occipital release. But again, you just use your assessment tools to find those. And every single case that you have, it doesn't matter what the name of the disease the person has or even the name of the condition. Break it down to what can you measure chiropractically, what can you do chiropractically, and how can you measure again chiropractically to monitor for change. Stay in your lane. I hear people say all the time, stay in your lane. That's what you can do. Don't get confused by all the other details. So the next time you come up against a difficult case and you're worried about, what does this mean? If you're not sure about something, refer it out. That's why there are other doctors. But break it down chiropractically, do the chiropractic part, do your job, and the patients are going to get better. All right, guys, have an awesome day. Hope that helps.